Okay, in our video series of neurology lectures, in this video we are going to talk about Parkinson's disease. We are going to discuss the presentation and management of Parkinson's in detail. Parkinson's has affected a very famous personality, Muhammad Ali, the boxer, a very famous boxer who was affected by Parkinson's disease. He was at the end of his life wheelchair bound. He could not move. He had a masked face. Muhammad Ali was a champion who also spread awareness about Parkinson's disease. Now we'll discuss what is Parkinson's disease. Parkinson's disease is a neurodegenerative condition that involves progressive depletion of dopaminergic neurons in basal ganglia. There is depletion of dopamine. There is loss of dopamine secreting neurons in the brain. When there is less dopamine in the brain, the movements of the body are affected. That is Parkinson's disease. This is the basal ganglia. Basal ganglia contains neurons that secrete dopamine, and there is loss of dopamine in Parkinson's disease, resulting in a movement disorder. It commonly manifests after the age of 60 years. Now coming to the etiology of Parkinson's disease, in majority of the cases we do not even know what's causing Parkinson's disease. Majority of the cases it's idiopathic. And genetic factors also play an important role. In genetic factors, there is accumulation of alpha-synuclein protein, abnormal accumulation of alpha-synuclein protein in the brain, and that forms the Lewy bodies. Those Lewy bodies damage the brain neurons that are secreting dopamine. Coming to secondary Parkinsonism is caused by exposure to insecticides. MPTP is an insecticide that causes secondary Parkinsonism, damage of the neurons that secrete dopamine. Certain drugs that block the action of dopamine cause secondary Parkinsonism, like haloperidol. Haloperidol blocks dopamine receptors. Metoclopramide blocks dopamine receptor. Reduced dopamine causes Parkinsonism. Trauma to the brain can also cause secondary Parkinsonism. A perfect example is Muhammad Ali the boxer. He received multiple punches to the head, resulting in microbleed that accumulated throughout his lifetime, and at the end there was loss of dopaminergic neurons, resulting in Parkinsonism. Hyperparathyroidism, hypoparathyroidism. In hyperparathyroidism, there is excessive calcium in the blood. That calcium deposits in the dopamine secreting neurons and causes loss of dopamine neurons. Decreased PTH. In decreased PTH, there is excess phosphate. And remember, excess phosphate, whenever there is excess phosphate in the body, that also causes calcium deposition, because phosphates loves calcium. Wherever there is excess phosphate, that excess phosphate in the dopamine secreting neurons will attract calcium towards it and causes calcium deposition and calcification and destruction of dopamine secreting neurons. Manganese element, contamination of food with manganese can also result in secondary Parkinsonism. So the major cause is idiopathic. After that it's genetic, and in majority of the cases it's either due to drugs or due to trauma. Now coming to the presentation of Parkinson's disease. Parkinson's disease is a slow progressive disease in which damage to the brain dopaminergic neurons takes place over years, and the symptoms onset also takes years to develop. It's a slow progressive disease where signs of Parkinsonism develop over 10 years. And motor signs initially when they present are asymmetrical. It's a movement disorder and initially it's asymmetrical. Maybe the tremor in one hand is much more than the tremor in the other hand. Tremor may be present in one hand and the other hand may be totally fine. In the initial stages, it's asymmetrical. In the later stages, patient can have tremor in both hands. The motor involvement can be symmetrical. But initially, the tremors or the motor signs are asymmetrical. In the preclinical stages, in the stages where the movement disorders have not yet developed, patient can experience certain symptoms. Those symptoms are non-specific for Parkinson's. Those are, at that stage, you cannot diagnose a patient with Parkinson's disease, because when the symptoms of tremors begin, almost 50 to 80% of the damage has already taken place to the brain dopaminergic neurons. In the preclinical stages, patient will have constipation. These patients, when you take history from them, these patients would tell you that, doctor, for the last few years I have been having severe constipation. Other than that, a very important symptom that they would tell you is anosmia. They would tell you that we have loss of sense of smell for the last few years. For the last few years, I have not been having a good sense of smell as I used to have. My family used to bring perfume to me. My grandchild would bring perfume to me and ask me that which perfume should I choose, and I was unable to smell it. That is anosmia. There will be sleep disturbance, there will be mood disorders, especially depression in these patients. So the one of the important earliest signs is constipation and anosmia, loss of sense of smell and constipation. Then after some years, motor signs begin to appear. Basically what's happening is that there is loss of dopamine in the body. That loss of dopamine causes reduced movement. All the movements are reduced. There is bradykinesia, reduction in the movement, rigidity. Since the muscles are not relaxed, they cannot move easily. So the muscles are rigid. There is a resting tremor. Now we'll discuss each one of these. This is the classical triad of Parkinson's disease. If two of these are present, you give the diagnosis of Parkinson's to that patient. Typical Parkinsonism presents like this: bradykinesia, rigidity, and resting tremors. We'll discuss each one of these in detail now. Now coming to bradykinesia, in bradykinesia patient will have decreased speed and decreased amplitude of movement. A decreased speed and amplitude of movement is because of the loss of dopamine. As I said, whenever there is loss of dopamine, there is slowness of the movement. Now if I ask you to move from this point in a room to this point, it will take few seconds for you to move from this place to another. But if you ask a patient of Parkinsonism within a room to move from this point to the door, even initiating the movement, even starting, even taking the first step will take a lot of minutes. It will take a lot of effort of that patient. That is the slowness of movement. These patients cannot move because they have loss of dopamine. The movements are difficult. The movements are so slow. It's such a difficult disease. In the later stage of diseases, these patients will develop akinetic mutism. In akinetic mutism, these patients will be mute. They would not speak because speaking also takes a lot of effort. A movement of muscles, articulations of muscle. These patients will not give any facial expressions to you. The smile, the anger, the facial expressions that we give while we are talking. Even these movements also slow down due to loss of dopamine. So these patients are mute. These patients are just sitting on their wheelchair without even giving any facial expression, any pain, any anger, any smile, any happiness. Everything is lost. The patient will be mute. The patient would be just lying on the chair or lying on the bed, not moving at all, because movements are difficult in this disease. Hypomimia, these patients will have masked faces, the faces that have no facial expressions. Hypophonia, loss of pitch of speech. The pitch of speech occurs due to vocal cord movement of the muscles, articulation. There will be loss of these patients will be just whispering like this. So these patients will be whispering because producing a pitch of sound also takes muscle movements. These patients will be having resting tremors that are present at rest. These patients will have a resting tremors like this on their hand, and as I said initially, the resting tremors will be asymmetrical. The tremor might be present in one hand, it might be more severe in one hand, and the other hand might be totally fine. In the later stages, they also develop tremors in both hands, but initially it is asymmetrical. The family would tell you that, doctor, most of the time we see that he is just moving his hands as if he is counting money. So that patient is having a resting tremor like this all the time when he is at rest. But this resting tremor improves when he starts to initiate movement. So the tremor is worse at rest, but when the patient tries to do anything, that tremor improves, that tremor gets better. Other than that, this tremor also disappears in sleep. So it is a pill rolling tremor as if someone is counting with a bead string or if someone is counting money. So there is a resting tremor that gets better with movement. It gets better, it disappears when the patient is asleep, and it is asymmetrical. That is the resting tremor present in Parkinsonism. Now, with bradykinesia and resting tremor, these patients are also having rigidity. Rigidity also plays a very important role in the movement disorder of Parkinsonism. Basically, these patients are having increased tone, increased muscle tone. The muscles are contracted. They are having increased tone. For movement to take place, one muscle has to relax and other muscle has to contract. As we studied in physiology, for movement to take place, certain group of muscle contracts and the other muscle group relaxes. But these patients are having all the muscles contracted. All the muscles are contracting. In that state, the person is still, that person cannot move. That is rigidity. The rigidity that is present in these patients is a cogwheel rigidity. What is cogwheel rigidity? I'll demonstrate the cogwheel rigidity to you. In cogwheel rigidity, when you ask the patient to flex the patient's hand, if the patient hand is flexed and you try to extend the patient's hand, in extension you will feel that there will be rigidity and there will be a period of relaxation like this. A period of rigidity after which there will be some relaxation. A period of rigidity after which there will be some relaxation like this. That is a cogwheel rigidity. This is a picture showing cogwheel. Rigid, relax, rigid, relax, rigid, relax, rigid, relax. So that is a cogwheel rigidity. As compared to lead pipe rigidity, in lead pipe rigidity, the muscles are rigid throughout the movement. If the patient's arm is flexed and you ask the patient to, you try to extend the patient's arm, you will feel that rigidity is present throughout the movement. There is no point where you feel that the hand has relaxed. So the lead pipe rigidity is the rigidity that is present throughout the motion. While the cogwheel rigidity is the one in which you feel certain jerks, rigid and then relaxation, rigidity and then relaxation. Now coming to Froment's maneuver. Froment's maneuver is a maneuver that is used to test rigidity in these patients. In Froment's maneuver, what you do is that you take a piece of paper and you ask the patient to hold the paper like this in the hand. And the doctor tries to pull the paper away from the patient. You ask the patient to hold it tightly. Now normally a person would hold the paper like this. But if the Froment's maneuver is positive, that patient would flex the thumb. And when he flexes the thumb, it will be easy for the paper to get out. Why does that patient flexes the thumbs? Because this patient is having rigidity in the hand. His muscles are rigid, so he is incorporating extra muscles to hold that paper, but he is unable to hold it and the paper is lost. So the normal Froment is like this. This is normal. This is abnormal. If the thumb flexes, it means that the Froment maneuver is positive and rigidity is there. These patients have postural instability, increased tendency to fall. But how do you test it? You ask the patient to stand with at their back, and what you do is that you hold them from their shoulders and you slightly pull them back. You give them a slight jerk. Normal person would take a certain step back or try to hold himself. He will stabilize himself because the muscles of the back are active. But these Parkinsonism patients, they have rigidity in their muscles. When you slightly pull them backward, they have increased tendency to fall upon you, or they'll fall backward, or they'll take 3, 4, 5 extra steps to stabilize themselves. While a normal person, if you pull them from the back, that patient will stabilize easily. Now this is a small video in which you can see that how the pull test is performed. Doctor is standing at the back, patient is standing in the front, and doctor tries to pull the patient back from the shoulders like this, and the patient cannot maintain the posture. Patient falls down. A normal person can maintain the posture. When you push the patient backward, the patient will maintain the posture, but this patient of Parkinsonism will fall back. So you must be present at the back to prevent so the patient do not fall back on the floor. And if the patient falls, you hold the patient. Now coming to Parkinson's gait, these patients have shuffling gait, small steps, short steps, shuffling gait. What is shuffling gait? Now I'll demonstrate the gait to you. These patients are normally having a stooped posture. These patients have increased tendency of fall due to rigidity of muscles. So these patients tend to be more flexed. They flex their back so that their center of gravity is closer to the ground and the chances of falling are low. So you will find these patients to have a stooped posture and they will have shuffling gait. They will be rubbing their feet against the floor. Small steps, and in those small steps they will rubbing their feet against the floor. That is called as a shuffling gait. Because movement of legs during walking takes so many muscle involvement, it incorporates so many muscles, but these patients are having rigid muscles, so they have to drag their feet on the floor like this, and they are taking small steps so that they do not fall. They are shuffling on the floor, taking small steps, dragging their feet. Now, when you ask these patients to move from this point to this point and stop at this point, now what happens is that this even initiation of the movement, even taking the first steps takes so much effort of these patients. It will take a lot of time for these patients to even take the first step. That is bradykinesia, slowness of the movement. And when they start moving, they are taking small steps, festinating, dragging their feet on the floor. And when they come to the stop point, they know that we have to stop here. They try to stop themselves, but they cannot stop themselves. And they keep moving forward due to the inertia of the body. Because stopping, applying brakes also involves contraction of many muscles, and the muscles are slow. The muscles are rigid. That's why these patients cannot even stop the movement on their own, and due to inertia, they'll move forward. That is the gait in these patients. Now, when these patients are here and you ask them to take a full U-turn, to turn around, what they will do is that a normal person would just simply turn around and move back. But these patients of Parkinsonism, they will take extra 3-4 steps to move back. For turning, they will have to take 3-4 extra steps, because turning is a difficult thing for these patients. And even many patients would fall when they are asked to turn. So you must be present around this patient and hold the patient if the patient has any postural instability. For the turn, they will have to take 3-4 extra steps. Another thing that you can do is that when these patients have any obstacle in their path, if there is a brick lying in front of them, or if there is a small thing, that is a small box that is lying in their path, and you ask them to step over it, it is a very difficult thing for these patients. These patients may even stop. They might not be even able to do this thing, because taking a step and moving above it and crossing it, it takes so much manipulation of muscles. It incorporates so many muscles. All the amplitude, all the acceleration, all the brakes, these things need to be synchronized properly. How amazing these movements are in a normal body that we do not even appreciate. In these patients, you can see that how difficult it becomes for a person to move when a single hormone is deficient in the body. So these patients will not be able to cross this obstacle. They will be standing here, they will be trying to cross it, but they won't be able. They will even fall. So that is Parkinsonism gait. This is a small video showing shuffling gait. Look at the small steps that patient is taking. And look, while she is turning, she has to take 3-4 extra steps to turn. And look at the loss of arm swing. There is no arm swing. These patients, when they are moving, when they are walking, there is loss of arm swing. So that is Parkinsonism gait. There will be freezing when these patients are standing at a point to initiate the movement. It is very difficult. They'll freeze at that point. There will be festination. I'll explain what is festinating gait. There is a very small difference. Although shuffling and festinating gait are almost the same, there is a very small difference in festinating gait. Propulsion. They will be stooped forward, and when they start the movement, they cannot stop it. They will have a propulsion in the movement. There will be decreased arm swing. The normal arm swing that we have when we move, they do not have that arm swing because it takes extra muscles. Now coming to festinating gait, in festinating gait there is a very small difference from shuffling gait. Basically what happens is when these patients are walking, taking small steps, and if there is a small obstruction in their path, this patient is walking and there is small obstruction in the path, if they try to overcome this obstruction, after that they have the tendency, they'll feel that they're about to fall, and when they feel they're about to fall, they'll take small short steps quickly. They have quick short steps to stabilize themselves. When the patient is moving forward and there is a small obstruction in the path and they are trying to overcome and they feel that they are about to fall, what they do is that they'll take small quick steps, short steps rapidly to stabilize themselves because they are unable to maintain the posture. That is called as festinating gait. Now this is a small video in which the doctor or the nurse tries to present a small obstacle to the patient's path and see how the patient moves forward then. Now after this, observe how the nurse provides an obstacle. Look, that is the festinating gait. That is the small shortened steps to stabilize the posture. But they have the very tender because they feel that they are about to fall. So they take small quick steps. That is called as festinating gait. These patients will have micrographia, small handwriting, because the movement of hands takes incorporation of muscles. So these muscles cannot move properly. So they have small letters because in everything you will see slowness of movement, in everything. In even the handwriting you can judge that these patients will have small handwriting. And in the handwriting you will feel the tremors, the resting tremors that is there when they are writing down. And in the start there might be large letters, but as slowly as they progress, it gets smaller and smaller and smaller. Micrographia, hypomimia. Hypomimia is the loss of facial expression, loss of facial. They have masked faces. This is the great legend Muhammad Ali having a masked face. This is another video of Muhammad Ali having the resting tremors. Now coming to atypical Parkinsonism. Atypical Parkinsonism is a Parkinsonism in which there are certain signs and symptoms that are not present in typical Parkinsonism patient. Now, if the patient is having signs of Parkinson's, with that patient is also having autonomic problems. Now that patient is having urinary incontinence, fecal incontinence. Now urinary incontinence, fecal incontinence are not classical features of typical Parkinsonism. If these autonomic problems are present, that is called as Shydrager Syndrome. Or if the patient is having orthostatic hypotension, autonomic abnormalities, the patient is having falls, and these falls are not due to the classical Parkinsonism features. This is due to the blood pressure. When you check the blood pressure of that patient while the patient was sitting, and when the patient is standing, after 3 minutes when you check the blood pressure, there is a significant drop in the blood pressure. There is orthostatic hypotension in that patient. That is Shydrager syndrome. And remember, these atypical Parkinsonism patients, they do not respond well to levodopa. Levodopa is a compound that is used for the treatment that we are going to talk about, that contains dopamine, is used for the treatment of typical Parkinsonism. In atypical Parkinsonism, levodopa cannot treat it very well. Coming to progressive supranuclear palsy. Progressive supranuclear palsy is also another atypical Parkinsonism in which the patient is having signs and symptoms of Parkinsonism, and with that patient is having vertical gaze palsy. Now that patient cannot look at the ground because the vertical movement of the eyes are affected. There is paralysis of the muscle that cause the vertical movement of the eyes. Now these patients have increased tendency to fall because they cannot look at the ground now. That is vertical gaze palsy. These patients will be looking at you like this. They will have a hyperextended neck just because to look at you, they will have to extend the neck because their eyes cannot perform the functions. Their muscles of eyes are paralyzed. Therefore, they have to extend their neck to look at you. That is vertical gaze palsy. Parkinson's dementia. Parkinson's dementia is the loss of memory that occurs over years. After the patient has diagnosis of Parkinsonism, that over years patient develop loss of memory. It is similar to Alzheimer's, but with that patient is having rigidity of limbs, visual hallucinations, and fluctuation in lucidity. Visual hallucination is a very important point in Parkinson's dementia. It is difficult to manage, and dopaminergic substances that are given to treat Parkinsonism, they even worsen hallucinations. The levodopa that we use, the levodopa is a compound that converts to dopamine and causes improvement in the rigidity, improvement in the bradykiniesias, but that levodopa has a very huge side effect, that it causes hallucinations. And these patients of Parkinsonism dementia, they're already having hallucinations. So for the treatment of rigidity, you are giving levodopa, but that levodopa is worsening the hallucinations. So that becomes quite problematic. In such cases, antipsychotics, atypical antipsychotics like quetiapine are used. Coming to diagnosis of Parkinsonism, there is no specific test till now that can be performed to confirm the diagnosis of Parkinson's. It's a clinical diagnosis. Now coming to the treatment of Parkinson's disease. Remember, Parkinson's disease cannot be cured. It can only be controlled. The damage has already been done to the brain. We cannot now reverse the damage. We cannot cure it, but what we can do is that we can control the symptoms of the patient and make the patient's life better. So not all the patients are eligible for the treatment. If the patient is having Parkinsonism and it is not interfering with the daily life, and the patient says, I am well, I'm fine with the diagnosis, I'm totally okay with it, it's not interfering with my life, I don't want medication. You do not need to prescribe medication, because it is not going to slow down the process of disease progression, or it is not going to reverse the disease progression. Treatment is given if the patient's disease is interfering with the daily life, as if the patient is having a dominant hand involvement, if the patient was a teacher and he used to write at the board and now he cannot teach because he cannot write at the board. So you need to treat that patient. And patient preferences are also important. If a patient does not want drugs, you cannot give drugs to that patient. If the patient wants treatment, and you have to consider the patient preferences. To understand the treatment, to understand the management of Parkinson's disease, you need to understand the pharmacology of Parkinson drugs. It's very easy, and I'll briefly skim through it. The main thing that is deficient in Parkinson's disease is dopamine. What you do in the treatment, you give the dopamine. You give the dopamine tablets. That dopamine is given in the form of levodopa tablet. Patient takes that levodopa tablet, that gets absorbed in the blood, and that crosses the blood-brain barrier. It enters the brain, it gets converted to dopamine, and patient has significant improvement of symptoms after taking levodopa. The problem is that when you give levodopa orally, there is a chance that levodopa will get degraded to dopamine in the blood, in the peripheral circulation. Before it has entered the blood-brain barrier, before it has entered the brain, in periphery it gets converted to dopamine, and when it gets converted to dopamine in the periphery, it causes significant side effects. So we do not want that. Therefore, a combination of levodopa with carbidopa is given, because carbidopa inhibits this conversion to dopamine in the peripheral circulation. Other than that, in peripheral circulation, levodopa can be degraded by an enzyme COMT. Catechol O-methyl transferase degrades levodopa to 3-MT. So we also usually give these inhibitors, COMT inhibitors, that prevent the degradation. Levodopa then enters brain. In brain, levodopa can also be degraded by COMT present within the brain. COMT is also present within the brain, and that can also cause destruction. Levodopa gets converted to dopamine. That dopamine can also be degraded by MAO-B inhibitor. So there are so many things, there are so many guards that are present before the brain to protect the brain. Before anything enters the brain, there are so many things that are trying to destroy it so that nothing reaches the brain from outside. So what we are trying to do is that we are fighting with each and every guard and taking the dopamine to the brain. So in the periphery, we give carbidopa and COMT inhibitor. When it entered the brain, COMT inhibitors are preventing the breakdown, and MAO-B inhibitors are also there to prevent the degradation. Now you have understood the mechanism. Now we'll go to the drugs. Levodopa carbidopa combination is given, and the amazing thing about it is that when the patient takes the drug, usually after an hour or so, after a few hours, there is a peak improvement in the effects. The patient feels significant improvement in the symptoms. Patient feels that he is free. He feels free because there is dopamine in the body and he can easily move. He can walk now. but then it reaches a peak. After that peak, the effect of dopamine starts to wear off. Then the patient again starts to feel that he is getting locked inside his own body. That is called as wearing off of dopamine. Other than that, when the patient was not on levodopa and you started the patient on levodopa, initially there is a honeymoon period in which there is significant improvement in the symptoms of the patient. The patient will thank you. The patient will be so happy. The patient will be so grateful that doctor, I was so worried about my condition and you treated me so well. Now I am totally okay. But you need to guide him that there is a certain thing called as honeymoon period in which everything gets better. But after that, the effects of levodopa start to wear off and the motor side effects start to appear. So the basic thing is that if the dopamine levels were low, patient has decreased movement, bradykinesia. If the dopamine levels are higher than normal, they cause motor side effects, excessive dyskinesias. Non-ergot dopamine agonist. There are certain drugs that stimulate the dopamine receptors. They include pramiprazole, ropinirole. MAO-B inhibitors that prevent the breakdown include selegiline, rasagiline. COMT inhibitors include entacapone, tolcapone. Tolcapone is not used because it is hepatotoxic. Tolcapone has an L in it, it damages the liver. Entacapone is used. Now, as I said that levodopa causes significant improvement in the symptoms, but there is a certain honeymoon period. After that honeymoon period, the effects of levodopa starts to wear off and the patient starts to develop motor side effects. It is also called as if someone is having post-retirement money in the bank. You can use it to certain limit. After that, there is nothing left. So in the young patients, we prefer to go to other drugs other than levodopa, and we reserve the levodopa for old patients because since within their lifetime they experience the honeymoon period of levodopa. And in the young patients, we give drugs other than levodopa. We try to control Parkinsonisms with drugs other than levodopa. If the patient's age is less than 65 years and the patient has no comorbs, the first line drugs include non-ergot dopamine agonists. Non-ergot dopamine agonists stimulate the dopamine receptors and increase the effects of dopamine. Ropinirole, pramiprazole. Other alternatives include MAO-B inhibitors, selegiline, that small little amount of dopamine that is present in the brain, that is naturally being produced in the brain. What you do is that you prevent the breakdown. You give these inhibitors that prevent the breakdown of that small little amount of dopamine that is naturally present, and it enhances the effects of dopamine in the brain. If these drugs fail, then what you can do is that you can combine levodopa carbidopa with these drugs so that the smaller dose of levodopa carbidopa goes to the patient. So if the patient is young, we try to reserve the dopamine for the end stages of the disease. But if the patient is old and if the patient is having multiple comorbs and if the patient is having severe Parkinsonism, levodopa carbidopa works excellently in these patients. So the first line is levodopa carbidopa, and levodopa carbidopa patients respond very well. There is a certain honeymoon period, and after that patient can develop motor dyskinesias. So when you are taking a history from a patient who is taking levodopa, the important thing is that you ask the patient that when he takes the tablet, how much time does it take for him to feel free, to feel that he is totally okay now, and after how much time does he starts to feel that the effects are going to wear off. Levodopa carbidopa effects are thought to be finite, and therefore it is said that it's just like a retirement money in the bank that you can use to a certain extent. If the patient develops motor dyskinesias whenever there is excess dopamine in the blood, patient starts to develop excessive movements. In that case, an anti-influenza drug, a flu drug, amantadine, is used. An important side effect of levodopa is that it causes hallucinations. And levodopa, it was important in the patients who are having Parkinson's dementia, because those patients were already having hallucinations and we are trying to control the Parkinsonism with levodopa, and that patient gets worsening of hallucinations. We control that with atypical antipsychotics, quetiapine and clozapine. If the patient is young and that patient is having excessive tremor, now remember that there is loss of dopamine in Parkinson's disease. But whenever there is loss of dopamine, there is a certain balance in the body. A balance in which dopamine is on this side and acetylcholine is on this side. Whenever there is loss of dopamine, acetylcholine increases. Acetylcholine becomes dominant and it causes tremors. The tremors in Parkinson's, you will be amazed that why is there rigidity, why is there slowed movement, bradykinesias, and there are also tremors at the same time. Basically, the tremors are due to excess acetylcholine that is causing the tremors. So in some patients, excess acetylcholine causes tremor predominant Parkinsonism. Patients are young. If the patient is young and the patient is having tremor predominant, anticholinergic drugs work very well. Anticholinergics include trihexyphenidyl, benztropine. These anticholinergic drugs are given and they are not recommended in old patients because as we studied that anticholinergics in old patients have severe side effects like urinary retention, blurring of vision. They experience severe side effects with anticholinergics. These patients are usually suffering from depression. SSRIs like citalopram can be used. SNRIs like venlafaxine can be used. For dementia, for loss of memory, cholinesterase inhibitors are used like donepezil. An important thing to remember is that if these patients get delirious, if these patients get agitated, aggressive, a normal response in the wards is that usually patients are given serinase injection that have haloperidol in it. Remember, haloperidol cannot be given in a patient with Parkinson's because haloperidol blocks the dopamine receptors and it worsens the effects of Parkinsonism. So in Parkinson's patient, haloperidol cannot be used. For an agitated patient, you use benzodiazepines like lorazepam, clonazepam. Deep brain stimulation is an important advancement in the treatment of Parkinsonism if the patient is having severe motor symptoms. Deep brain stimulation is done. And remember, deep brain stimulation is done and the patient is awake during the process. The patient is awake while the process of deep brain stimulation is being done. This is a picture showing the patient and this is the machinery doing the deep brain stimulation. You might have heard of the surgeries in which the patient is asked, if the patient is a musician and that patient is asked to play violin or guitar during the surgery, at the same time they are operating on the brain. That is deep brain stimulation. What they do is that they target subthalamic nuclei or internal globus pallidus, and at the same time they ask the patient to play the violin, to play the guitar, and they are stimulating the certain areas of the brain. That is deep brain stimulation in the treatment of Parkinson's disease. Before going into the summary, if you liked my video, please click on the subscribe button and check out my other lectures on neurology. In summary, we talked about what is Parkinson's disease, what is the etiology, what are the signs of Parkinson, the preclinical stage, constipation, the triad of Parkinsonism, bradykinesia, resting tremor, rigidity. If the patient's age is less tremor predominant, anticholinergics are used, Parkinson's Gait, Shydrager Syndrome, Supranuclear Palsy, Parkinson's Dementia, treatment of Parkinsonism, the mechanism of the drugs that are used. If the patient age is less than 65, no comorbs, levodopa carbidopa is avoided, and if the patient age is greater than 65, levodopa carbidopa is preferred. Levodopa responds very well honeymoon period. After that, there are dyskinesias. If the patient age is less and there is tremor predominance, anticholinergics are used. Treatment of depression and dementia, deep brain stimulation. If you liked my video, please click on the subscribe button and check out my other videos on neurology lectures. Thank you very much.